Bismillahirrahmanirrahim. Dear students, today we'll be discussing respiratory tract infections and its classification, pathogenesis, and other modalities which are of interest according to your text. Learning outcomes with regard to the topic that at the end of this lecture, you will be able to define respiratory tract infections, classify upper and lower respiratory tract infections, describe pathogenesis and clinical correlation of sinusitis, pharyngitis, tonsillitis, define and correlate bronchitis, bronchiolitis, and pneumonia, differentiate between lobar and bronchopneumonia on the basis of clinical and anatomical classification. So before we begin with the respiratory tract infections, we will have a glance at the anatomy of the respiratory tract. And first, we will go through the upper respiratory tract infection. And what is upper respiratory tract is consists of. So it consists of a nose, pharynx, paranasal sinuses, portion of the larynx above the vocal cords. You can see here that this is the part of the nose and nostrils and nose, and you can see that soft palate, hard palate, and this is nasal cavity. And then pharynx, you can see pharynx, the wall behind the mouth, and then paranasal sinuses, which gives a cushioning effect to the system, and then portion of the larynx above the vocal cords. So this is the upper respiratory tract, anatomy of the upper respiratory tract. So as we move downwards, uh, then we see that the beginning of the lower respiratory tract. It consists of larynx below the vocal folds, trachea, which is also called windpipe, and then it goes into the bronchial tubes, right and left bronchus, and then it it differentiates into the alveoli, which performs the exchange of gases. So this is a brief perspective of lower respiratory tract, and I hope that you have gone through that from the anatomy department. So as we move forward with respiratory tract infections, respiratory tract infections can be classified into upper respiratory tract infections and lower respiratory tract infections. Upper respiratory infections consist of common cold, cytositis, pharyngitis, epiglottitis, and laryngotracheitis. And with reference to lower respiratory tract infections, it is comprised of bronchitis, bronchiolitis, and pneumonia. Upper respiratory infections are comprised of, as you are aware, that common cold, sinusitis, pharyngitis, epiglottitis, and laryngotracheitis. And they represent an array of clinical symptoms like fever, runny nose, sneezing, and weakness. So these symptoms are overlapping and has to be carefully determined with regard to what is happening to the patient. Dear students, as we move forward with the etiology of upper respiratory tract infection, you will be able to learn that upper respiratory tract infections represents the most common acute illness which have been evaluated in the outpatient settings. Upper respiratory infections ranges from the common cold, typically a mild self-limited Cato syndrome of the nasopharynx, to life-threatening illnesses such as epiglottitis and COVID-19. So, common cold continues to be a large burden on society, economically and socially. And as you can see in the current scenario, that common COVID-19 has also contributed significantly to that burden and loss of lives, economic loss, and all the other related activities. So the most common virus encountered which has been rhinovirus. Other viruses include the influenza virus, adenovirus, enterovirus, RSV, that is respiratory syncytial virus, and SARS-CoV-2 virus. So, in addition, bacteria may cause roughly 15% of sudden onset of pharyngitis presentations, and the most common is Streptococcus pyogenes, group A Streptococcus. You can see here some structures of the mouth, like this is soft palate, and this you can see here, this is hard palate on the upper side, and this incisors, and then tonsils. You can see here tonsils both sides, and uvula and tongue, and the lips. You can see here, this is the structure of the mouth. And organism can attain entry to the respiratory tract by inhalation through the nose and through the mouth in the form of droplets and aerosols, and can invade the mucosa of these openings. So after gaining entrance, they can result in the destruction of epithelium, which results in redness, edema, hemorrhage, and formation of an exudate, which results in secretions and can result in portal of exit for the microorganisms. Here we will discuss clinical correlation between upper respiratory tract infections like common cold, sinusitis, pharyngitis and tonsillitis, epiglottitis, and severe laryngotracheitis. So, in common cold, what can you encounter is that runny, stuffy nose, sneezing, with usually no fever, but maybe sometimes it represents with fever. Sinusitis, thick yellow or greenish discharge, post nasal drip, nasal blockage, tenderness around cheeks and nose, and which is due to the inflammation of the sinuses. In pharyngitis and tonsillitis, you can encounter significant pain in swallowing during swallowing, and cough, fever, and visible white patches at the back of the throat and in the over the tonsils, and also sometimes headache. In epiglottitis, which can result in difficulty in breathing, you can estimate that why there is a difficulty in breathing, muffled speech as due to the swelling of the vocal cords, drooling, and stridor. And it means that saliva is coming out of the mouth, and when while breathing, there is a considerable sound which can be heard from outside. And in severe laryngotracheitis, cropping cough, trachepnea, stridor, and cyanosis. Cropping refers to an infection of the upper airway which obstructs breathing and causes a characteristic barking cough. The cough and other signs and symptoms of crop are the result of swelling around the voice box, that is larynx, windpipe, that is trachea, and bronchial tubes, that is bronchi. Diagnosis of common colds can usually be done on the basis of clinical signs and symptoms, and but in some cases of other upper respiratory tract infections, bacteria cultures of throat swab can be beneficial when you are suspecting pharyngitis, epiglottitis, and laryngotracheitis. In some cases, blood cultures like epiglottitis can be helpful in diagnosis of the condition when the patient's condition is not improving. And with the recent invention of molecular diagnosis, the things has been become more, I think, has been more relaxing and more helpful in the diagnosis of viral infections of the upper respiratory tract. Lower respiratory tract infections can be divided into bronchitis, bronchiolitis, and pneumonia. Bronchitis is mainly a disease of the adults and can be caused by bacteria and virus, while bronchiolitis is a major cause of infant respiratory tract infection, and the main cause is respiratory sensitive virus, while pneumonia is the infection of one or more both lungs with the involvement of the alveoli. In this slide, we can compare bronchitis and bronchiolitis one by one. So, in bronchitis, the main factors are environmental, which seems to be more in the form of environmental stress like smoking and also bacteria and viral infection. While if we see that bronchiolitis is a viral respiratory disease of infants and it is primarily caused by a virus and also other viruses like influenza virus, respiratory syncytial virus, and adenoviruses may be involved. And in bronchitis and bronchiolitis, both involve inflammation of the bronchial tree. And in bronchitis is usually preceded by an upper respiratory tract infection, and while in bronchiolitis it results in inflammation and sometimes necrosis of the respiratory epithelium with eventual swelling. While this bronchitis can be divided into acute and chronic bronchitis, and chronic bronchitis presents with a persistent cough and sputum production, and it is majorly a disease of the elderly and can be a cause of chronic obstructive pulmonary disease. So here we will talk somewhat about the pathogenesis of the bronchitis and bronchiolitis. In bronchitis, it can be seen that bronchial mucosa becomes uh, hyperemic and edematous and results in production of copious bronchial secretions, and also increase in the number of mucus-producing cells in the airways, resulting in obstruction of the airway and also as well as inflammation, which also contribute to the obstruction of the airway. Coming to bronchiolitis, we can see here that bronchial and bronchial valves are taken due to the exudate, which is majorly made up of necrotic material and respiratory secretions, which results in narrowing of the bronchial lumen and resulting in airway obstruction. This production of in bronchitis, this production of mucus inflammation and bronchial secretion results in loss of mucociliary function and also to the actual destruction of the respiratory epithelium, which leads to the respiratory failure in future. And with regard to bronchiolitis, areas of air trapping and atelectasis develop and may eventually contribute to respiratory failure. So, atelectasis is the collapse or closure of a lung, resulting in reduced or absent gas exchange. It is usually unilateral, affecting part or all of one lung. It is a condition where the alveoli are deflated down to little or no volume, as distinct from pulmonary consolidation, in which they are filled with liquid. As we are done with bronchitis and bronchiolitis, now we move on to pneumonia. And pneumonia can be defined as an infection in one or both lungs, and it causes inflammation in the alveoli. The alveoli are filled with fluid or pus, making it difficult to breathe. So you can see here that normal bronchiole and alveoli, they are filled with air, and venules and capillaries. And when in pneumonia, you can see that there is accumulation of fluid in the alveoli, whether exudative or whatever the cause is, resulting in blocking of the alveoli and the loss of pulmonary function. Definition of pneumonia. Pneumonia also can be defined as inflammation and consolidation of lung tissue due to an infectious agent. And consolidation can be defined as inflammatory induration of a normally aerated lung due to the presence of cellular exudative in alveoli. You can see here this is an healthy lung and healthy alveoli and bronchiole, and uh, with the accumulation of fluid and blood cells in the alveoli due to the infection, the alveolar walls are thickened due to the edema and inflammation, and resulting in, when you do an X-ray, there is an opacity of the lung part is seen. So this is known as consolidation. How does pneumonia occurs in an individual? Pneumonia कैसे होता है? You are already aware that there are certain body filters which keeps the organism entering the body, like hairs in the nose, mucus secretions, antibodies like IgA, which are there to protect the body from the attack of the organisms, which can result in some disease. And these barriers keep the lungs from becoming infected. But due to some reasons, these pathogens, organisms can enter the lungs and cause infection. And this is more likely to occur when the the immune system of the individual is weak and is compromised, and the pathogen load is very high, and overcoming the barriers of that individual, and in some cases body fails to filter the organisms. So this may result in compromising the capacity of the lungs and resulting in infection in the lungs, which can result in consolidation of that part of the lung where the infection has occurred. In this slide, we will talk about the predisposing factors for the pneumonia, या फिर हम इसको ये किस तरह कह सकते हैं कि वो अवामिल जो नमूनिया की वजह बनते हैं, लाइक सिगरेट स्मोकिंग, upper respiratory tract infections, alcohol consumption, corticosteroid therapy, old age या बुढ़ापा, recent influenza infection, pre-existing lung disease, and reduced defense against host defense. इस तरह हम इसको उर्दू में इस तरह कह सकते हैं कि सिगरेट स्मोकिंग, अपर फेफड़ों की इन्फेक्शन, शराब, कॉर्टिकोस्टेरॉइड से इलाज, बुढ़ापा, मौजूदा इन्फ्लुएंजा इन्फेक्शन, पहले से मौजूद फेफड़ों की बीमारी, बैक्टीरिया के खिलाफ महदूद मेज़बान दिफा. इसके अलावा अदर अवामिल जो नमूनिया की वजह बनते हैं, लाइक नेज़ोफेरेंजियल और मैदे की रतूबत को निकलना, लाइक एस्पिरेशन ऑफ नेज़ोफेरेंजियल और गैस्ट्रिक सिक्रीशंस, and bacteria introduced into lower respiratory tract. And this aspiration of nasopharyngeal gastric secretion can result due to the mobility or reduced conscious level, vomiting, dysphagia, eclasia, or severe reflux, or nasogastric intubation. And with regard to bacteria introduced into lower respiratory tract, बैक्टीरिया का नीचे वाली सांस की नाली के अंदर घुसना results in can result due to the endotracheal intubation or tracheostomy, infected ventilators, nebulizers, and bronchoscopes, and dental or sinus infection. These are the contributing factors which can result in the form can present in the form of pneumonia. Pathogenesis of pneumonia presents with congestion. This stage occurs within the first 24 hours of contract pneumonia. During congestion, the body will experience vascular engorgement, intra-alveolar fluid, which is a proteinaceous exudate, and often of multiple bacteria in the alveoli. And you can see here this fluid in air sacs, which represents the congestion or pneumonia of an individual. So there are four stages of pneumonia. It starts with consolidation, red hepatization, gray hepatization, and resolution. So we will describe in latest slides and describe each of the stage in detail. So as we are discussing the stages of pneumonia, consolidation is the first stage and it usually occurs in the first 24 hours. What happens that alveolar air is replaced by cellular exudates containing neutrophils, lymphocytes, and fibrin, and you can also see the congestion around the alveolar walls and due to the in the capillaries surrounding this area. And ultimately, what happens that the infection spreads to the hilum and pleura very rapidly and resulting in pleurisy. And this is a chest radiograph, and you can see this area of opaque, which is a result of consolidation of the upper lobe of the lung. And with reference to pleurisy, you can see that this is inflammation. The pleura becomes inflamed, and it is also called pleuritis. And during the breathing, there is a deep, sharp cutting pain in the chest. Red hepatization occurs 2 to 3 days after consolidation. And as you can see that it is characterized by the presence of many erythrocytes, neutrophils, desquamated epithelial cells, and fibrin within the alveoli. And in this pic, you can see that this is the pic of a normal lung, and that hepatization, the lung has become hyperemic, and it resembles that of the liver. And the capillaries, alveolar capillaries, are engorged with blood, resulting in giving a red color to this part of the lung. So you can, and in addition, you can see that fibrinous exudates also fill the alveoli. So this is the red hepatization. Gray hepatization is the third stage, and it occurs 2 or 3 days after this red hepatization. So this can be regarded as an avascular stage as there is disintegration of red cells and hemosiderin, and the lung appears gray brown to yellow. The pressure of the exudate in the alveoli causes compression of the capillaries, and this you can see that this is a gross appearance which resulted in gray hepatization. And the leukocytes migrate into the congested alveoli, and the lung appears gray brown to yellow. Resolution is the fourth and last stage of the pneumonia, and in which you can see many characteristic changes due to the resorption and restoration of the pulmonary architecture, and a large number of macrophages enter the alveolar spaces, which results in the phagocytosis of the bacteria-laden leukocytes, and then finally the consolidation tissue rearrays, and the fluid infiltrate causes sputum, production of the sputum. And this figure can give you a pictorial view of the pathogenesis of pneumonia, that you can see a congestion and consolidation, which can, after 2 to 3 days, convert into red hepatization, and then what happens, that gray hepatization disintegrates, red cells disintegrates and are taken over by white blood cells and lymphocytes, resulting in gray hepatization, and finally the resolution and aeration of the consolidated area is evident. And what we can see, that this fibrous inflammation may extend to and across the pleural space, causing a rub heard by auscultation, and it may lead to resolution or to organization and pleural adhesions. Now we will have somewhat about classification. We can divide classification on the basis of anatomy, that is called an atypical classification, and on the basis of clinical knowledge, that is called clinical classification. So with regard to an atypical classification, we can divide the pneumonia into bronchopneumonia, lobar pneumonia, and interstitial pneumonia. So bronchopneumonia mainly affects the lungs in patches around the bronchi, while lobar pneumonia is an infection that involves a single lobe or section of a lung. And in interstitial pneumonia, you can see that it involves the areas in between the alveoli. Coming to clinical classification, it can be divided into community-acquired pneumonia, pneumonia in elderly, and nosocomial pneumonia. So, coming back to community-acquired pneumonia, it can be subdivided into typical or subclassified into typical, atypical aspiration pneumonia, and nosocomial can be subclassified into hospital-acquired pneumonia, ventilator-associated pneumonia, and healthcare-associated pneumonia, and also pneumonia in immunocompromised host. So the community-acquired pneumonia, which is also called HCAP, this is an infection of the pulmonary parenchyma, and it can be defined as pneumonia that is acquired outside the hospital in the community. And the most common identified pathogens are Streptococci pneumoniae, Haemophilus influenzae, and if we talk about atypical bacteria, then most commonly Chlamydia pneumonia, Mycoplasma pneumonia, and Legionella species, and viruses are involved. Although this is not very common in our region, but still it can be identified as a cause of community-acquired pneumonia. Hospital-acquired pneumonia is also called HAP, and it can be defined as pneumonia that occurs 48 hours or more after admission into the hospital, and which was not present at the time of admission. And this hospital-acquired pneumonia is example of nosocomial infections, which is due to unsterile procedures and through the environment, through another patient, and all other factors due to the unhygienic conditions. Ventilator-associated pneumonia develop 48 hours or longer after mechanical ventilation is given by means of an endotracheal tube or tracheostomy. So, ventilator-associated pneumonia results from the invasion of the lower respiratory tract and lung parenchyma by microorganisms. The most common microorganisms are typically bacteria, causing early onset are Streptococcus pneumoniae, Haemophilus influenza, methicillin-sensitive Staphylococcus aureus, antibiotic-sensitive enteric gram-negative bacilli, E. coli, Klebsiella pneumoniae, and Enterobacter species. What happens that intubation compromises the integrity of the oropharynx and trachea and allows oral and gastric secretions to enter the lower airways. HCAP or healthcare associated pneumonia includes any patient which has been hospitalized in an acute care hospital for 2 or more days within 90 days of infection. It is important. And he or she is residing in a nursing home or long term care facility and have received recent antibiotic therapy, chemotherapy, or wound care within the past 30 days of the current infection, which has immunocompromised the individual, and also attended a hospital or hemodialysis center. Atypical pneumonia presents clinically with subacute onset. Fever may be present, or if present, may be intense, and the production of minimal sputum. And you can see here that these infiltration, you can see infiltration in the lower lobes, and this represents the atypical pneumonia. On microbiological examination, sputum does not reveal any predominant microbial etiology on routine smears or cultures. So it may be difficult to diagnose atypical pneumonia microbiologically, but clinically, and the clinical correlation is more important in diagnosis of atypical pneumonia. So aspiration pneumonia occurs when food, saliva, liquids, or vomit is breathed into the lungs or airways, leading to the lungs instead of being swallowed into the esophagus and stomach. This is the chest X-ray. You can see infiltration in the lower zones or low lobes of the in an individual who is presenting with this infiltration and infection of the lung after aspiration, some aspiration of some liquid. So there may be episodes, apparent episodes of aspiration, and there may be bronchial obstruction that can result due to the bronchial obstruction by a foreign body. That can be seen in nocturnal esophageal reflux, a prolonged session in the dental chair, epilepsy, and alcoholism. The most common organisms are involved are usually anaerobes, but aerobic bacteria are also involved. In the end, we can summarize what we have done in this lecture or in this presentation. We have discussed upper respiratory infections, common cold, sinusitis, pharyngitis, epiglottitis, and laryngotracheitis symptoms, and have correlated these symptoms and these infections, upper respiratory tract infections. We have also discussed somewhat about COVID-19 and how it affects the upper respiratory tract, and the lower respiratory tract infection causes infection, and also we have discussed lower respiratory tract infections. We have compared bronchitis and bronchiolitis, and then we have talked about pneumonia, its definition, its stages, and different stages and classification. For any queries, please email me at following address: shams@frpmc.edu.pk. And thank you for remaining with me and bearing with me with regard to this presentation. I hope it works for you people who are listening it carefully. Once again, thank you.